So the starting point for this evening is really to talk about what is an aneurysm, because it's a word that's used quite a lot, but I think a lot of people don't really know what it is. People often say, is that a clot in the brain, or not quite sure. So what it is it's an abnormality of a blood vessel, and in this case, we're talking about blood vessels in the brain. And what happens is you get a weakness in the blood vessel. So this would be the blood vessel here. And if in one spot you get a bit of weakness, you get a bulge sticking out the side of it. And that bulge is called an aneurysm. And it gets referred to having parts to it. So there's the dome, which is the sort of outer edge, the sac, which is sort of, the sac like of a bag. And the neck is the bit where you sort of have the entrance into the bag. And that's what an aneurysm is. This is what they look like in real life. So this is looking under the microscope during an operation. And you can see a blood vessel running here and coming out there and along here. And then in between, you've got this little berry looking like shaped thing, which is an aneurysm. And people ask, well, whereabouts are they? And it's always really difficult to explain because it's sort of right at the base of the brain. If you put your fingers to your head, you could point from almost any direction because it's kind of right in the middle. If you look at the image on the top right here, shows where incisions are made for operations. And we make incisions along the hairline here, and then remove a piece of skull in this area, which is just above the eye and in the temple area. Usually it's quite a bit smaller than what's depicted there. And then if you look sort of underneath the brain effectively, that's where the aneurysms form. So it's not really in the brain, it's sort of underneath the brain is the way to think of where they are. So I'm having to use my arrow to move the slides for some reason. There we go. So then I guess first thing is, how common are they? And they're actually probably more common than people realize. And so in the general population, about 3% of adults have them. Now, saying exactly how many people have them depends on what age you're talking about, because once you have an aneurysm, it doesn't disappear. So the older you are, the more people there are that have an aneurysm. So, but the broad brush thing is that for middle-aged people, about 3% of people have one. And the more common in women, by quite a margin, 70% in women, 30% in men, for reasons I should say that we really don't understand very well, for something that's such an obvious difference. And the next statement is meant to say largely don't occur in children. I'm not sure why the children dropped off there. So it's really a disease largely of adulthood. They can occur in children, but they usually kind of almost a different problem. And they, as I say, they form in your 30s, 40s, and 50s. So how do people become aware of having an aneurysm? Well, the truth is most don't. So 3% of the population don't know they have an aneurysm. It's much lower than that. And the reason they don't know about it is because symptoms from aneurysms are really rare. The brain has essentially no pain sensation. And basically it's a situation where the vast majority of aneurysms people don't know about. And if they do know about, they discover it when they have a scan for other reasons. Typical reasons are headaches, if they've had a head injury. People often have scans for hearing loss or tinnitus, if they have strokes. And actually lung cancer is quite a common one because people with lung cancer smoke a lot, and aneurysms are closely related with smoking. So the vast majority people don't know about. Some they know about because they've had a scan done for other reasons. And then an occasional one they'll discover when they burst. But that is really the small minority. And what happens when they burst? Well, you get bleeding on the brain. So it's difficult to explain to people what that bleed is like, because the aneurysms are at the base of the brain. The bleeding happens at the base of the brain. And if you've ever seen an image of a brain, you have lots of sort of crevices in the brain, as it were. And the blood fills those crevices at the base of the brain. So this is a scan of somebody who's had a bleed. And you see this almost star-shaped white shape here. You might think it's a stick man as well, with a head up top, 2 arms, and 2 legs. And the aneurysms sit here right in the middle of that star, as it were. And the blood tries tracking out through those crevices. And that's something that we call a subarachnoid hemorrhage. And that's a result of an aneurysm rupturing. And that's a very serious event. But when that happens, about a third people will die, a third will be left disabled, and just a third will recover from that. So it's a very hard thing to put across to people that aneurysms are much more common than you realize. Most people don't know about them. Most don't cause any symptoms or problems, and just an occasional one will cause a lot of trouble. So then the question is obviously, well, how likely is it that they're going to burst? Well, the broad figure is about 1% per year. But it really varies a lot from one person to another. And the biggest factor is how big they are. And essentially, if they're small, and in this context, when we talk about small, we're talking about less than 7 millimeters, they very rarely burst. It basically equates to about 1 in 1,000 per year, or what we put there, 0.5% over 5 years. But 1 in 1,000 per year really is quite a low number, and 90% of aneurysms are in this category of being small. So only 10% of aneurysms fall in these categories that I've listed below that, where the risk gets a bit higher. Although still, even at 7 to 12%, it's only 2.5% over 5 years. So there are often issues more of what's my lifetime risk rather than what's my risk this year. Other factors in how likely they are to bleed is the aneurysm location, having high blood pressure, having had an aneurysm elsewhere that has previously burst. And when I say elsewhere, I'm talking about in the brain. I mean, there's some evidence that at older age there's a bit increased risk. But overwhelmingly, the issue is what size they are. So then the next question is, well, how are they treated, or can they be treated? And there's broadly two approaches to try and treat an aneurysm. One is colloquially called coiling. The approach is what we describe as endovascular, which is where we put a needle either in the groin or in the wrist, and we get into a blood vessel there. And then we can follow the blood vessels with what we call catheters, which are very fine, long tubes. And we can take those tubes, depicted here in gray, up the blood vessels, all the way up to where the aneurysm is. And then we have something that's described as a coil. I often say to people, it's a bit like a curly hair, because if you can pull it straight, but if you let it go, it curls up. And so if you pull it straight and you can push it up through the tube of the catheter, it comes out the end, and it starts in this image to curl up. And you keep pushing it up, and it curls up into a ball, like in the third picture here. That makes a coil ball. And then the people always wonder, well, what happens then? Well, then you put a little electric current through it. And then by electrolysis, the metal degrades and it releases, and you can pull the catheter out again. And so that's coiling. And this is a different depiction of what a coil looks like. And this is what it looks like in real life. So here you've got a blood vessel running again. You can see an aneurysm sticking out, and you can see the coils sitting in the tip of an aneurysm. And this was an aneurysm that was incompletely treated and needed further treatment. So then the other treatment is colloquially called clipping. This is what people would consider open surgery. Although when we say open surgery, everything is done under the microscope, so it's relatively small openings. This is the image I showed you at the beginning. That shows how we make an incision in the hairline for surgery. We make this opening in the skull just above the eye and in the temple region. As I say, in real life, we make it quite a lot smaller than that. You can make it down to 3-4 centimeters, that sort of size. And then you get a view under the microscope that's in the middle here, where essentially you're looking underneath the brain and you're seeing the blood vessel coming out the base of the brain, and you see an aneurysm sitting there. And this is what it looks like in real life. Again, images from a microscope where you can see predominantly here a blood vessel. And then you can see off to the top right here where the aneurysm is. And this is a little metal clip. And you can see two blades, one in front of it, one behind it. And this is the applicator. And then you can release that, and you can see how it clamps down. So the blood can still flow down the blood vessel, but can't flow into the aneurysm. So what about if your aneurysm isn't treated? So some aneurysms are treated, and instead we follow them up on scans. And we do that with MRI. Exactly the regime varies quite a lot from unit to unit. But typical sort of thing would be to scan them after 1 year, and then 2 years after that, then every 3 years, every 5 years. You slowly stretch out the length of time between scans as you get more and more reassured that it's stable. And the reality is the vast majority stay stable. So we do enormous numbers of these scans, and 95% just show everything looks the same and everybody's reassured. 5%, however, shows some signs of growth. And usually when I say some signs of growth, it's still relatively small changes, a millimeter here or there. But when we see them grow, then the theory is that that's a more dangerous aneurysm, and maybe that's one that should go ahead for treatment. So why am I even talking about not treating these aneurysms? Why aren't they just all treated? Well, in medicine, we're always weighing up what are the risks of our procedure and trying to weigh it up against the risks of leaving things alone. So in this case, you're talking about the risk of aneurysm rupturing in your lifetime. And the issue is, what I told you before, is that those risks of aneurysm rupture are not necessarily that big depending on your exact aneurysm. And the risks of the procedures, while not bad, do still have some significant risks. And there is a risk of getting bleeding from the aneurysm or having a stroke during the procedure. So you want to be sure you absolutely need the procedure to go ahead with a risk profile that's about 5% risk of complication. And that's why quite a lot don't get treated. The issue is exactly which ones should we treat? And the struggle there is we don't really have a good grip on what our lifetime risk of an aneurysm rupturing is. That's actually how I am involved with the Polycystic Kidney Disease charity, because they supported a study that we started and really set it in motion with the funding for the pilot work for this, which is all about trying to work out what somebody's risk of an aneurysm rupturing is. So they funded the initial parts of the study together with the local charity Smile for Wessex, which then got momentum and then got funding from the Royal College of Surgeons of England and more latterly from the National Institute of Health and Care Research into larger grants. So what's the study doing? Well, as I say, we want to know the exact risk for any individual of their aneurysm rupturing. And to work that out, you basically need to follow up a lot of people for a really long time. A lot of people, so you can study all the differences that makes one person different from another. And for a really long time, because if you're a patient with an aneurysm and you're trying to decide if to treat your aneurysm or not, you're not really interested if your risk next year is 0.5% or 0.1% or 1%. You're interested to know, in my lifetime, say 30 years, what is the risk of aneurysm rupturing in that time? And as I say, that's not something people have a very good grip on. So in the ROAR studies, the risk of aneurysm rupture study, we've collected baseline data. So that's gone through all the notes and scans from 20,000 patients with aneurysms. And we're managing to follow so many people up in the long term because the UK, through the NHS, has fantastic databases of hospital admissions and deaths. So we can link all those patients to those hospital admissions and deaths. We can intermittently see who's had an aneurysm rupture and see, therefore, in the long term, what those risks look like. So that's the overall aim of the study, to generate personalized predictions of long-term aneurysm risk. And that links perfectly into what we're talking about tonight and the PKD charity, because one of the first questions people ask is, well, I have an aneurysm, but I also have PKD. So are the risks that you've just told me the same for me, or are they different? And the short answer is nobody knows. And that's why this study is happening, and hopefully we'll be able to answer that. So getting more into the specifics of PKD and aneurysms. The first question people ask is, well, are you more likely to get an aneurysm if you have PKD? Well, the answer is pretty confidently yes. The question is exactly how much more likely. It's probably about 3 to 5 times more likely. And when people have done studies where they have screened lots of people with PKD, typically you see about 12% of people have an aneurysm. But you might remember at the beginning I said it depends a little bit what age you're talking about. And a lot of that screening will have probably happened in relatively young people. And if you look at an equivalent age to what I quoted of 55, 60 years, then the chances of having an aneurysm is probably closer to 20% in patients with PKD. There's no specific differences known between PKD1 and PKD2, although I emphasized the known. I don't think we really have an answer on that. And there is also no known relationship to disease severity, but nobody's really looked at that adequately as well. The thing that we do know is that aneurysms run in families, and that's whether you've got PKD or not. And in general, about 10% of aneurysms, patients with aneurysms will have a family member affected as well. That's aneurysms in the brain, and it's not related to aneurysms of the aorta, in the abdomen, or elsewhere in the body. So for some reason, aneurysms in the brain seem to be a different condition and a different problem. In PKD, we see the same pattern that typically aneurysms run in families. And so, they either don't run in families or they tend to do run in families. So then, if they are more common in people with PKD, should we have screening for patients in PKD? And the answer is probably. The question is exactly how. And the most common approach we see is to screen anyone who's got a family history for aneurysms. We do that using MRI. We do it with a specific type of MRI called MRA, which from a patient perspective is exactly the same as an MRI. It's the same scanner, it's the same machine. It's essentially, I liken it to what channel you tune your TV in to. It determines what you see on your television screen. Well, it's a bit like that on an MRI. It's exactly what channel you tune into. The channel we tune into is MRA. And of note, it doesn't require contrast, which means you don't need a drip to have anything put in. And that means there's no risk to your kidneys from any contrast, although I would emphasize the evidence that contrast that we use for MR, that it causes harm to kidneys, is actually pretty limited. This MRI imaging, well, you have it done once, but that doesn't mean you can't develop an aneurysm in the future. And so we typically repeat it every 5 years. And then the last question is really, what age do you start? And so I generally recommend starting 5 years before the youngest family member who's been affected previously. I emphasize this is the most common approach. There's lots of variation on it, and there are no UK, European, or US guidelines on the right thing to do. And that's probably because opinions vary. And they vary for a number of reasons. The first, simply because it's debated exactly how common they are, and they have to be common enough to warrant doing these scans. It's also unknown how many run outside of families. So you might agree, well, if there's family history, we should be screening. We don't really know if they don't run in your family what your risk is, and therefore whether you should have screening in that circumstance. It's also really unknown exactly what the costs of these screening programs are and whether those costs can be justified. And it's also unknown to what degree scans create anxiety. So sometimes it creates a focus for people to focus on, actually causes more stress than it avoids. But the biggest factor why there's variation in opinion about screening is it's unknown what the risk of rupture is if you do find an aneurysm. And if you don't know what the risk of the aneurysm rupturing is, then you don't know whether it should be treated. And the most fundamental thing about running a screening program is if you're going to screen for something, you want to screen for something which is going to cause an action. And the risk is that you screen for something and you find an aneurysm, potentially a small one, and there's no action to it. And that's really what the issue that generates most variation in opinion, whether you should be screening, and to how many people you should be offering that screening. I should say I'm a proponent of screening, and I do screen, but I'm giving all the viewpoints here. So then I guess the last question is, well, if you do have an aneurysm, is there anything I can do other than treating it that might reduce my risk? Well, the things that you can do are pretty limited, and they're pretty clear-cut. We know smoking is bad, and we know blood pressure is bad, and they're both probably about triple your risk of an aneurysm rupturing in the future. They also increase your risk of having an aneurysm in the first place. Nothing else is essentially proven to make any difference. Question people often ask is, well, what about exercise if I have an aneurysm? Can I do that? Well, I always point out to people that aneurysms are a problem of the wall of a blood vessel and of the pressure of blood inside the aneurysm. And we know that exercise is good for your blood pressure, and we know that exercise is good for blood vessels. So I'm convinced that it's better to exercise regularly than to not exercise. So other questions that come up are, well, does it matter how well my PKD is controlled or how severe it is? And does that make any difference to my risk? We simply don't know. I suspect that it probably doesn't matter much other than its influence on your blood pressure. And that's the biggest factor in things. The other question comes up with transplants and how that affects things. And that can act in two directions, neither of which are known to be an issue. So the first of all is that you can have a transplant with an aneurysm, either because it's small and it doesn't need treating, or because it's big and you have treated it. Also, if you have a transplant, it probably doesn't change the long-term risk of your aneurysm rupturing. So yeah, the two are relatively independent. So in summary, aneurysms are more common than most people realize. They rupture much less frequently than most people assume. And therefore, the decisions whether to screen or to treat are very nuanced. And I'd like to emphasize and thank that the PKD charity is funding and helping resolve these questions through funding the ROAR study. I hope it was interesting. I hope I answered most things you could think of, but equally, I hope it provokes a few questions. I'll stop the share. And I don't know how you want to run this. Have we got... I haven't had time to look what's going on in the chat.
Hello, it's Alison here. I think we might have temporarily or permanently lost Susan, so I'll step into the breach. We've got some questions that have come up via the chat that if I put those to you, perhaps there's something you could answer. Somebody's just said what a great presentation that was, how helpful it was. And somebody else has asked, why did you choose to study aneurysms? That you obviously have put the subject over so well that somebody was interested to know why you chose to study them.
Oh wow, that's been a journey. That's been a journey because obviously first I had to get into neurosurgery and then I had to get into aneurysms. I ended up in neurosurgery because, as the famous neurosurgeon says, the brain is the crown jewel. And there's nothing like it in the universe. So I wanted to know more and study it more. And aneurysms, because it's such an impactful event for people, and it's something that we can intervene on. And yeah, it's hugely gratifying to be able to treat a condition that is both very problematic but does have solutions.
Well, I'm looking, someone's just popped into the chat. So before everyone's phoning their consultants tomorrow saying, can I have a scan? Someone's asking, should we ask our consultants for a scan to check for an aneurysm? You did hit on that and say there's regional variations. So
I think the short answer,
we've got lots of people who'll be wondering the same.
The short answer is if you've got a family member, I think it's pretty clear you should ask for a scan. If you don't have a family member affected, it's really controversial, and it's going to be hit and miss who you ask whether they're going to take you up on it or not. Sorry, have you frozen there?
Yes, I think my colleague Susan's having some problems with her internet this evening. So I'll have a look and see whether there's another question. Somebody's asked, do blood thinners create a risk of bleeding? This worries me when I go in for surgery and I'm given them. Would that have any impact on an aneurysm?
So it's a really good question. It's a really common question. It is also a question that we hope to detail in the ROAR study. The short answer is with everything we know, it doesn't make a difference. And the way I explain that to people is having thin blood doesn't make things burst. The issue is an aneurysm bursting. If you have thin blood and your aneurysm bursts, it's likely to bleed more because the bleeding won't stop. But it isn't what initiates the problem. So we let people have anticoagulants normally with an aneurysm. And indeed, there is some research into aspirin, which is a very gentle blood thinner, effectively. And aspirin is anti-inflammatory. And there is a theory, I should emphasize not more than a theory, that aneurysms form because there's inflammation in the blood vessels, and that aspirin might reduce that inflammation a little bit, and it might therefore stabilize aneurysms. So that there are trials where people are actively giving aspirin, if that gives a reassurance to the concept of having blood thinners.
Okay, that's great. Somebody else has asked, does having an aneurysm increase the risks around having surgery? So not just surgery related to the kidneys, but any sort of surgery.
Effectively not.
Okay.
There would be some risk. Presumably, there's a higher risk of being a smoker, and being a smoker is put in. There's a higher risk of having high blood pressure, and those things put you at greater risk from other procedures. But there's nothing from the aneurysm itself. No.
Okay. Somebody else has asked, are aneurysms caused indirectly by kidney dysfunction or changes in the blood vessels as a result of the PKD1 and 2 variants?
So it is the belief that the genetic defect is influencing how the blood vessel walls form, and that affects the brain as well as the kidneys. Does that answer the question?
Yeah, I think so. Um, that's a really useful answer, actually. Somebody else has asked, um, have you come across patients who've said they'd rather not know whether they've got one or not? And what's your response to those patients?
I definitely have patients who say that, and it's a perfectly valid approach to take. There's a reason we see people before people get to scan. It'd be easy to say, "Oh, we've had a referral. They meet these criteria and they want a scan. We'll just book you a scan." But we always meet people before it to talk about the implications of it. And you basically have to be prepared for a few scenarios, and that is essentially to find that you don't have an aneurysm, and that you still need to have scans in the future, which, as I say, it brings it to the fore every 5 years that you're being screened for an aneurysm, whereas, it does, play on people's minds, whereas perhaps it's easier to forget about it if you don't have the scan. Probably the big one is you have to be prepared to find an aneurysm that is then relatively small and then nobody wants to treat. And now you have an aneurysm and nobody's doing anything about it, which clearly, causes stress for people. And then you need to be prepared for finding that you have an aneurysm. And although you're not under any obligation to have it treated, but there's no point having the scan done if you then don't go through with one of the procedures I described to you earlier, which, as I say, I think if you have an aneurysm, they're good treatments, but they're not completely harmless. So, those are all reasons why you have to be comfortable with those outcomes to undergo screening.
Somebody else has asked, is it just brain aneurysms? My father had stomach aneurysms and he had PKD. Would that have been part of the same thing?
I think I'm a little bit at the limit of my knowledge there,
Oh,
actually.
yes, sorry, yes.
I don't come at it from a PKD perspective. I'm not aware of aneurysms being an issue with PKD, that aortic aneurysms.
Okay, that's great. Somebody else has said, and really just more of a comment, but they've said that they've got 3 members of their family who passed away due to aneurysms and PKD, and they feel really, really appreciative and thankful that their consultant continues to send them for regular scans, and that that's something that's really positive for them. Um, Somebody else has asked, how often would you rescan if no aneurysm was detected? if there's an identified risk of or family history of PKD and aneurysms.
So once people go into screening, I rescan every 5 years, and you vary a little bit how long you carry on with. Usually, the screening program starts winding up around the age of 60, by which you've usually got quite a long period of follow up, and you're getting quite a lot of confidence that there's nothing going to be there.
And I see some questions starting to flurry in now about what I would say truths or myths. So it's working out which is which. Someone's saying that they worry, stress, and anger, could that contribute to a bursting aneurysm? Is it possible?
This is a really loaded one to answer. Chronic stress only through putting your blood pressure up chronically and the damage that the blood pressure does. Extreme surges of blood pressure can make an aneurysm rupture. But the thing that I always say to people is your blood pressure, even when you're not stressed, fluctuates enormously. And if you cough or strain at the toilet or something like that, your blood pressure shoots through the roof. And these are things that happen every day that you have no control over. And therefore, my belief is that if an aneurysm were to rupture because of stress, that aneurysm was going to rupture anyway. It might not happen that day, but it was going to happen the next day or in the next week.
So imagine your theory there would be very similar. Someone's asking about weightlifting. Does weightlifting increase the chance of an aneurysm bursting?
Pretty much the same answer to that.
Yeah, well, my thought was when you said straining for the toilet, I'm thinking I'm straining to lift.
Yeah. It's we get into the minutiae. So there are types of bleed on the brain that are not from aneurysms. And oddly, we see those not infrequently in young male weightlifters. But bleeds from aneurysms, I must admit, I can't think of ever having seen somebody weightlifting and having one bleed. But that possibly is also because it's a pastime of relatively young men, which is not really the group of people who tend to be affected by this problem.
Fantastic. I see Sandra's popped something into the chat and someone else has given it a thumbs up, so they must have been thinking the same. When it comes to treatments, what determines whether an aneurysm is coiled or clipped?
Yeah, there's lots that go into that factor. So there are some, ultimately patients get to choose. But that is largely where the feeling is that an aneurysm is equally treatable by both techniques. And there are some aspects that push you towards one technique or the other. The sort of more hard stop, shall we say, is some locations are difficult to get to with surgery. And some at the base of the brain, with the classical locations, what we call basilar. That's difficult to get to with surgery, so you would pretty much always go to that with coiling. The flip side is some are difficult to treat endovascularly, largely because of the shape. I'd almost have to go back to pictures to illustrate the problem. But if you remember, the aneurysm is like a circle and it has a neck at the base of it, where my thumbs are. And it needs to have a bit of a neck for the coils to stay inside it. And as that neck gets bigger, there's nowhere for the coils to hang in, and they essentially fall out of the aneurysm. Now, there's lots of little tricks and new devices to try and deal with that. But essentially, the less defined that neck is, the harder it gets for the endovascular approaches, and the more likely you are to looking at surgery.
Now, I know some of the questions that came in advance, people were asking questions about transplantation and post-transplant. Am I right in thinking that risk post-transplant, etc., would be the same risk as prior to receiving a new kidney?
Pretty much, we think, except that your blood pressure might be better.
That's great. Alison, can you see anything that I've maybe missed there in the Q&A? I've dropped out a couple of times due to a good internet connection tonight.
Somebody did ask, does having migraines long term increase the risk or act as an indicator of having an aneurysm?
Yeah, really good question. I didn't get into that actually on the slide. Um, so uh, there's two parts to that question. Does it increase your risk of having an aneurysm? So the migraine in itself doesn't increase your risk of having an aneurysm. I guess the question is more, is having headaches or migraine a sign that you have an aneurysm? And that's an incredibly difficult question to answer. The first thing is I'd have to differentiate between migraine and headaches. So migraine typically have additional symptoms to just straightforward pain. So if you have features that are migraine, then it's not related to an aneurysm. So aneurysms don't cause migraine. The really murky world is, can they cause pain in the form of headache? And I think the traditional medical stance on this has been there's no pain sensation in the brain. Aneurysms don't cause pain. It's probably more complicated than that. The problem is that pretty much the most common reason for having a scan is headache. And I've told you 3% of the population have an aneurysm. So if you're going to start scanning thousands of people with headaches, you're going to find quite a lot of people who have an aneurysm. And there's no way of disentangling if that headache was because of the aneurysm or you found the aneurysm because you had the headache. The practical information that probably you can use for this is if you look at what happens to headache after treatment, then the studies that are around suggest that about 30% of people's headaches get better with treatment. That means 70% of people's headaches don't get better and presumably were completely unrelated.
Okay. And someone's put in, I think they suffer themselves with an aneurysm. Should their children or adult children, the youngest I think is 28, should they be screened?
Yeah, I mean, the short answer is yes. Again, there's a little bit of discussion at what age, but at 28, they're already very close to my 30-year-old threshold where I start. And certainly, if their parents had an aneurysm at a young age, I'd start now.
And I think I think more of a fun and interesting thing fits into the conversation. What's the biggest aneurysm that you've witnessed? We've spoken about these tiny ones, which are millimeters.
Yeah.
So we'll have extremes.
So these are extremes. I'd have to measure it up. I actually am due to operate on somebody with the largest aneurysm I've come across so far, which I'm guessing measures almost 7 centimeters across. But that is a wild exception, and that's I don't know how many thousand patients with aneurysms I've managed over the years, and yeah, that's the biggest.
Now, I'm trying to remember in your earlier slides, you did put up different symptoms and different things. And I think you perhaps had ringing in the ears, which to me is tinnitus, which someone's put into the chat. Is tinnitus an indicator of an aneurysm?
No, definitely not. So if you are, I purposely didn't put signs of aneurysms in because they're so rare, and I think it gives you the wrong impression if I put symptoms to look out for.
Yeah.
Headache is the closest, but it really would have to be a very atypical headache to flag as a concern. And you only really get it with large aneurysms. So you definitely don't get headache with small aneurysms. So the belief is that with very large aneurysms, you start stretching the structures, the lining of the brain around it, and that causes the pain. There's a few odd locations where you can get double vision, where if an aneurysm presses on one nerve that's in that area and your eyes don't point quite in the same direction, that gives you double vision. That would be a sign of an aneurysm. But I don't know what percentage of our aneurysms present with that symptom. I'm guessing it's about 1% or something like that. It's a tiny fraction.
Now I'm just scanning through, Alison. Has something caught your eye there?
I can't see any more. I think some overlapped a little. So I think those were all the distinct separate questions.
Yes. Now, if this is your kind of opportunity, we have a few moments left in our call. If there is any burning questions, either pop it into the chat just now, or I do invite you to raise your hand if you want to ask it in person. Do remember, we cannot answer personal medical questions. Oh, a compliment coming in, really useful, and you've answered a lot of my questions from someone. And someone's just asking, are there any risk differences based on the location of an aneurysm?
Yeah.
And they went on thereafter to say where they have one, and it's the paraophthalmic nerve.
Paraophthalmic, yes. So the good news is that's the one you would choose to have. So there is a little bit of difference in locations. There is, I'm afraid, controversy, and we only work with what studies there are, and different studies show slightly different things as to what are the higher risk locations. I'd have to get into technicality, naming what those locations are. But the only thing that's clear is that the paraophthalmic in all studies is the lowest risk location.
Now, something that does come up frequently in our community across the board, so it's not necessarily to aneurysms, in general across the board of PKD, is life insurance. Can having an aneurysm affect life insurance? But the diagnosis of PKD in itself gives a loaded policy and makes it slightly more difficult to get a mainstream policy company to cover you. So I'd assume an aneurysm, you're adding more weight.
As you might imagine, insurance companies are a law unto themselves, and I can't say I've got any good grip on exactly how they think or what they do. I think outside of PKD, they don't penalize aneurysms that badly. And the general approach that I see is that patients either tell them, I have an aneurysm that I've been told doesn't need treatment, or they say, I have an aneurysm that needs treatment and I've had it treated, and the penalty is relatively minor, is my sense. The only situation in which insurance becomes very problematic is an aneurysm that's not being treated or is waiting to be treated.
Someone's popped into the chat. They were adopted into a family, so there's no known family history should they request a scan.
Yeah, it's a question very close to my heart. I should say that the ROAR study, I've been spent the whole summer writing a grant for a couple of £1 million to obtain basically genetics from everybody in the ROAR study to try and get to the bottom of the genetics of aneurysms beyond PKD, because PKD is basically the only genetic cause we know for aneurysms. And if you look at the stats of how many, because in PKD we sort of use a slightly broader definition of family, we just basically say anybody with family. But the strict rule, it should be 2 first-degree relatives, and that's what is used for patients without PKD. And first-degree relatives are your parents, your siblings, or your children. Now, I've told you that aneurysms don't really happen in young people, so you can discount your children. And there's plenty of people who are single children, or even if they have siblings, only half of them will get whatever gene it is we're talking about. So you might not have them affected. And your parents might have been affected by something at a time when medically the information was limited and you might not know. So I've actually done estimates of this, and I estimate that, as little as, as many as 90% of people might not actually ever be able to meet that criteria in having 2 first-degree relatives. So it's a very long answer to the issue of family history. But I think if I had PKD and I didn't know my family history, I would I would consider myself the same as if I had a family history, and if I wanted a scan, ask for it.
Now, our community love to hear about research. It gives us, I think, all that hope that there will be someday something positive in PKD. So Faith's asking, is there any research ongoing into the preventative medication and treatment of aneurysms?
Yes, the number of things considered are probably relatively small factors. So it's the aspirin, what I told you, is a study that's running, and there's studies running of seeing whether lowering blood pressure lower than what is just normal, whether that helps. Beyond that, to be honest, that's one of the ambitions for the genetic study that I'm trying to launch. Because usually you get insights what medicines are going to work by understanding what causes the problem in the first place. And so there's the hope that if we can understand the genes that the groups of genes that drive aneurysms, that then it becomes more obvious what medications we should be trialing. But I should say also on the treatment side, if you need treatment, I mean, treatments today are completely different to what they were 30, 40 years ago. They're probably already very different to what they were 10 years ago. It's evolving very quickly with the risk profile of both surgery and quitting.
Sneaking one in here, I'm aware we've got 5 minutes before we have to close. Flying, is it safe to fly with an aneurysm?
Unreservedly, yes. So the reason unreservedly is, well, I've never treated anybody who's come off the plane with an aneurysm that's burst. And the other side is that with that stat that I gave you, 3% of people having an aneurysm, the average 747 is going to have more than a dozen people with an aneurysm on it. And I'm not aware of the hospitals surrounding Heathrow being flooded with problems.
Now, there's many, many messages of thanks coming through the chat. What I'll do is I will collect them and send them over to you tomorrow. So on behalf of our audience and everyone at PKD Charity, I really say thank you. And it's a huge thank you. It's not just your time for the presentation, it's the preparation that's obviously went into it. And thank you for bringing it to a language myself and many of our audience would understand. And well, that's very difficult for some medics, but it was very well done.
Thank you. It's been an absolute pleasure. And thanks for all the work that the charity are doing.